Who owns data and contemporary issues? Data is everything and everything is data. I think in the past probably couple of years, you would increasingly hear this characterization of what data is and what it is not. And I heard this podcast not too long ago about the rest of science. I don't know who else follows that podcast. And there was this interesting talk about comparing the amount of raindrops in the clouds versus the amount of data in the cloud. And that was quite an interesting discussion. But I think the truth is, exponentially and increasingly so, the amount of data created, captured, and consumed worldwide is at an all-time high. And there are a lot of opportunities and risks associated with using data properly, but effectively, most importantly, safely in our context of health and research. You may very easily find yourself in this Taoist half cup full, half cup empty situation, like whether you think the current data provision and accessibility and power is a good thing, or it is something to be feared of. And there might be tons of initiatives, narratives in this big wide world that may shift you to one way or the other. So NHS colleagues here, data saves lives, absolutely, as the health data scientists. It's very similar feelings, I suppose, and narratives in the European health data space discussion, where they use the same slogan in promoting that cross-European data sharing for primary care and secondary data use. And the government, along with ONS, have steadily produced data strategy in allowing more efficient data use. So you might think, these are good news. We should use and can use data in effective and society-changing ways. But there are also other factors that might draw you to the other side. Well, start with Palantir. You hear all these parliamentary debates and justifications on why it should and should not be contracted. I'll leave the detail aside. There are these talks and online reportings about potential data leaks on different studies and issues. The most recent one on the Guardian investigation, whilst the study groups themselves would deny any naturalistic data leak. I presented this not long ago with the Bioethics Society about the Cambridge Analytica data leak. I'm surprised to find that none of the students knew what it was. Maybe I was a bit old now, but that's another situation where might make you double think when what type of data is being used and shared for public good. And what's missing is we've been very caught up in evaluating how full this cup is, but sometimes we didn't think about how we would use this cup or how we would drink this cup, if I could extend this analogy then to its extremes. Who is here to make well use of this data truly for public good? And who gets to say to who holds, process, and own these data? I think you need no introduction to the potential risks or the half cup empty narratives. And the reason I put these slides on is to, I suppose, remind everyone of a common shared historical trauma or danger in the case of, well, unethical use of data. We start with the drones and all that, and that's a satellite image from Bombchask, where satellite images was used to target areas, villages, and that's a depiction of the damage and the impact. And the Nuremberg law and a similar story Peter was telling me the other day, and how the Netherlands has the best administrative censuses at those times, and that in turn was used by the Nazi to target and, well, kill the Jewish people at that time. And so these are some shared history and contemporary issues in the potentially shared cultural history in Europe about attitudes to use, own, and process data. And you could still see that narrative and fear that exist in the UK in particular. But in several slides later, I'd like to put down this UK framework for just a moment, for half a day, and to see how that imagery and imagination of data ownership forms and whether it can be challenged, changed, and reformed. So here are a few very classical views of data ownership and understanding. So we can attempt to understand data as a piece of property, a piece of land, or we could treat it as intellectual property, right? So that's the use of data that should be respected by others. You could treat data as a fundamental right, the right to be forgotten, the right to be used, the right for personal data to be treated differently as a different categorical information. And there's also the contextual rights to access particular data, meaning, for example, during COVID, maybe for public health and surveillance needs, the different UKHSA upstairs might have the special rights to access identifiers in the state of individuals. But you might quickly notice that none of these four explanations are fully satisfactory in describing how a piece of data can be owned or treated. And there are three big words that the EU Law Commission has used to describe this states that data is non-frivolous, non-exclusive, and inexhaustible. So basically saying that you can't use up data like you could with any other properties. You can't compete with others in the use of the same piece of data. Well, researchers may argue otherwise, but that's not the same. And it's inexhaustible, as in data won't be gone because more people are accessing it and using it. So I suppose these different thoughts are challenging the fact that how can the typical view, the legal view of data as a property be applied in this age when there's a vast explosion in data availability, discussion, processing. And hence you would see this quick shift from ownership to processing in most of our legal frameworks, in GDPR, in the common law duty of confidentiality. The focus is more on justifiable processing and use of data rather than focusing on the ownership of that data. And you might realize we actually don't own a lot of our own data. Like we don't own our own health data. When we go to universities, you're working for the staff, you don't own our own like HR data. Or maybe academics, so Elsevier would ask you to report all of your personal identifiers with a particular surveillance need. And again, once it's provided, it belongs to them. It's not your data anymore to a certain extent. And the context in health in particular has two key differences in using data for operational care, so direct care of patients, and for research and secondary use. This characterization might be familiar, but is actually different across the world. So if we just cross the channel a little bit, in Europe, they differentiate use of data into primary and secondary use of data, where care planning or service design and delivery is classed as secondary use of data rather than primary, which makes sense because it is the secondary use of data and not involved in using active identifiers. But I want to plant the seed that these understandings or legal frameworks that we are so familiar with in the UK health setting might not be universal. And there are reasons, potential motivations in why it is set up in the way it is. And in particular in the health space, we have this concept in the UK on Section 251, where it allows or empowers data processors to use identifiable confidential patient information without consent for defined medical purposes, including research. So again, you might be surprised to hear that this is, again, a partial outlier in the global health system. Not everywhere you could choose to opt out from the sharing of your own data for research purposes. But in EU, for example, in the proposals in the EHDS, some might challenge you to go even further by saying, why can't we opt out from the sharing of primary care data? So that is an option in some of the EHDS discussion, and not yet so in the UK on when that control of data is given to the people in their use of their own data. So there are some exceptions. where people can opt out of sharing their data for research purposes in the UK. And here's a quick dashboard of the proportions and numbers. And what has yet to be said often enough in research, at least in the applied research, is the cost of opt-outs. So there are ongoing work in eChild, in UKLC, and in other cohort studies in understanding these costs of differential opt-outs, where some population groups, in our cases, mostly minoritized ethnic populations, are consistently more likely to be opting out. And in that sense, affects the downstream outcome of including them in health research and how we generate evidence and understanding of our world. But it's really a chicken and egg problem. Perhaps it's a lack of trust leading to opt-outs, leading to poorer data, worse service, and ended up back in more mistrust. And I think this view is very important in our current topic of understanding data processing and ownership. If we can't get the people on board, how can we prepare for these vastly changing and diversifying landscape of the promises of linked data? I'm trying to bring you back to the cup half full side of things, where there are so many possibilities and innovations that stems from linking health data or other types of data with our vast provision of other options. How do we speak to the public? How do we convince data processors and owners that it is a good idea and that can be done in a safely ethical manner? So there are also variations across the board in data ownership models. For example, when would you be comfortable for your local authority to use your data without asking you first? So you might spring your mind to either end of the cup, but there are some positive examples in, for example, local authorities working closely with water providers in saying, okay, if this household's income is below a certain threshold, we would automatically apply a certain discount to their water bills. So you might think, okay, that's for public good. But the critics might ask, why didn't you just ask the person how much they're earning? Or why didn't you just ask? And they could give you that data themselves. So the problem isn't about using this directly, the data with or without consent, but whether they've brought the peoples with them as they make these decisions. I'm going to quickly bring you several other cultural variations in how the concept of opting out and use of data varies just in Europe. So you might have heard about the Odyssey work in the Netherlands, where they had a full populational coverage of basically all individuals, occupation, their social networks and health, income at an individual level. And as a rightful citizen of the Netherlands, there is no option to opt out, because in their culture, in their current running, they believe it is part of the social license to become a citizen of the Netherlands to be a part of this network. And you don't hear a lot of complaining from the people in the Netherlands too. And very similar stories in the Nordic countries. You have individual coverage registries in Finland, Sweden, Iceland, Norway for decades. And again, there is this strong trust, I believe, in the using and processing of that data. Well, if we flip to the other side in the US, then you see other types of practices where private banking or insurance-driven data collection is sometimes encouraged, right? Where there is no one state or centralized data processing and control. It leaves room for financial incentives to build their own data and collecting them in other means and based on benefit and not trust. So questions to you for the rest of the day, as we would hear about discussion around balancing between innovation that Johnny will bring, as we hear about international examples from Molly, as we think about the public voices from our contributors and from Pedri, and Andy would help us close in gathering our thoughts into thinking, what is our positioning? Who needs to be in the room? What needs to be prioritized? And how can we work with the public and communicate well? So I hope these serves as some welcoming and introduction questions to help us think collectively as a group on where we are and where to go forward. So that's my introduction talk, and thank you, everyone. We will be in, I'm sorry ahead of time, so we have about 10 minutes for quick Q&A, because our next speaker, Johnny, is in the other room in another important meeting, so we'll have to wait for him to finish his other meeting to come. But I'm very happy to take any questions and start the discussion now.
Yes, yes, but I think the room is small enough. It's fine. So yeah, I'm Fran Torres. I work at Policy in Practice, and I am part of the team who does the work with local authorities and water companies. And yeah, I was actually interested in hearing from you and probably others in the room, like about if you could develop a bit more that slide on the tensions, like when it is acceptable and when it is not, and when factors such as stigma, because people won't always say, if they know that they are eligible for additional support, they might not be willing to accept it. Of course, now maybe I'm contradicting myself, but yeah, they basically want to hear about your thoughts on, is it on the gray areas of that acceptability, basically.
Yeah. Thank you, Fran. I was meaning to say, yes, that's your work in Policy in Practice, and well done. I think that I have two broad answers to that. One, I think the question is more about whether there are linkage-specific questions about that particular use of data that we should be asking for permission for such linkage. So that is almost turning things back on its tail. I don't know this expression, but turning things around and seeing a lot of current or legacy permissions for data linkage, of health data linkage in the UK, is given at the dataset level. Well, there's a general agreement in the types of data and the types of usage of such data, but not at the level as specified as, okay, we're driven by the collaboration between the service provider and the local authority in delivering a product. So it's almost again, crossing the fine line of, is this direct care of patients in the framework of health, or is it generating data for secondary research? And the second point is I share your thinking about, there are cultural variations and individual variations in whether something like accepting public benefit is deemed as like an acceptable thing to do. So in Hong Kong, in my culture, people are ashamed to take any public benefit because they think they are being a burden to the wider government or the wider society. And there might be enclaves of population in the UK that would be rendered invisible if we rely only on administrative data, for example, to define need. So, administrative data defined as access for benefits, but there might be other types that would give you more hints. So it's not an answer, but it's a yes, that's a very good point. Any other quick thoughts? Yes, Shaden.
Thanks, really, really interesting presentation. And just on what you just said, yeah, I grew up in the States, and something like the NHS, for example, might be considered quote unquote a handout, which is how they refer to sort of public benefits in the way that, it's different. I have two things. So the sort of chicken and egg around particular groups that are not being represented in data, and the sort of, the sort of tension of like, we want them to be able to feel comfortable sharing their data so they are represented, but then there is understandably a lot of hesitation around that too. I think something that is just maybe not mentioned with as much weight is the fact that ethnic categories aren't great either. you know, like my own ethnicity is like never on anything. And we can see that ethnicity is reported differently from data sets that we even try to link, like justice and education. And I think correcting that is also really, really important. And if I can just throw in one more thought, is that we see a lot of really amazing public dialogue work around opting out. And I really struggle with, you know, taking the outcome of that and applying it to a population that hasn't had the benefit of the dialogue either. Because I almost feel like if you're given the option to opt out without properly understanding what that even means, knowing what we do, I almost feel like it's more of a harm than not offering it at all. And I think that isn't often discussed either.
Yeah. Quick response to the second part. Almost feels like the same line of criticism for democracy, isn't it? Like when you give the power to the people, when you give the option of choice to the population, and the problems become whether they've got the sufficient information for them to make an informed decision and choice. And when they do, we respect that. It's true. And a common risk, or a fear, I suppose, not a risk, that we are sometimes hearing is, well, we think they will only reach that point of having sufficient understanding of the matter after all these like discussions and dialogues that we've had. And that is, I suppose, a phenomenon we are exploring, Catherine, as part of the Sprint working group, and exploring what are the potential minimum information that's required for our participants who have very little experience with data, rightfully so, to develop that informed consent or that knowledge about the topic to give their opinion. But there are unanswered questions yet too, right? How much of those dialogues depends on the actual notion or the actual linkage, the actual topic of linkage? Like, was it about financial data? Is it different from criminal justice data? How is it different? How should researchers ask or approach those questions, etc.? And back to the problem of ethnicity and categorization. Yeah, I did a lot of work in that area too. I can say it is our role as researchers, I'm speaking to the researchers in the room, that we have to find ways to make meaning and interpret it in ways that are loyal to a particular understanding. And it's not to say that that's the only way to understand ethnicity or interpret it in our models, but we have to take a stance and make things clear and theorize. Good. I think we have one more question. Time for one more? Yes.
I work in the commercial research space and predominantly working with secondary care organisations within the NHS. One of the big challenges that we have is that we as a commercial organisation can't have identifiable data.
Yes.
Anonymised information. But in my capacity as the Research Governance and Ethics Lead, I find that challenging because as anonymous information, an individual doesn't have any rights around it. And you get decreased utility as a result of that anonymisation process and things like that. So I wondered what your perspective on whether that pursuit of anonymisation is a kind of false prophet that actually, from what a lot of feedback we get from our patient advisory panel is, well, how can you maintain accuracy? Accuracy is really important to us. So how do you balance that tension whereby you've got identifiable data, you can maintain its accuracy, maximum utility, but the question is that you need to have anonymous information on the data.
Yeah. Ooh, that's a loaded question. I don't think I can give a very satisfactory answer to where's that fine balance between sufficient anonymization, whether pseudonymization is good enough for some level of public access. I think what I can say is the current model, a lot of the current models in data access in research partially built on the concept of cohort data or primary collected data, where there is a lot of checks in classifying different types of data into when that level of anonymization is required. So you get special categorized health data, you get personal identifiers like ethnicity, as we discussed, as a special category, and that is deemed traditionally as sort of types of data that require a higher level of protection. In health, my understanding is we held the same higher standard of protection compared to some other social care data or other types of education data, where there is this more prevalent belief and understanding of that space, health data needs to be protected and separated. I think it is a strength in the UK to have that view and to have that understanding of health. And I wanted to suggest that it is not necessarily counterproductive to have data anonymized, because I think the problem that you are pointing is to whether we can develop a back-end interactive spine of data or communication across data platforms that allows sharing and safeguarding. And I think there are ongoing processes that Julia in the room is developing in supporting that development. And so I think your question points more to the cogs in the machine, the wheels in maintaining the free flow or safe flow of data, rather than as a data provider or downstream user of secondary data, how can we ensure the quality of the accuracy of the individuals or identifiers?
Section 241 to allow individuals just outside of their activities.
Yes.
To anonymize it and then send it through to us. We do a lot of work to ensure that a month or 2 months ahead of that process, patients are made aware that we're doing this, and we'd say, I opt out, they can opt out any time after. But once the data is anonymized, national data opt-out doesn't apply, and the data is already here. Your rights under GDPR don't apply if it's anonymous information. At that point, the data could be used for whatever, with a lot of checks and balances, but at that point it's gone. Whereas if it was maintained to be identifiable, an individual can leverage their rights to opt out under common law or under GDPR at any time thereafter. So I think that's something that isn't naturally appreciated.
Yeah, no, I share your view in the sense that that conversation needs to be more to the front in deciding at what level that of control or ownership that patient has on the use of their data. I would almost guess that Johnny will be talking about it in a bit more detail in our next talk. And maybe I'll pass on straight to you, Johnny, because we are time for our next week, but we'll come back.